printed out my prototype list here, and at the top it says cardiovascular and renal system drugs, and at the top it says drugs for treatment for hypertension, which hypertension is one of the issues that we have with the heart. Okay, what can cause hypertension, do you think? Vasoconstriction. So the arteries are getting squished or squozen. How do they get squished, do you think? What makes them constrict?
The angiotensin that's released by the kidneys.
That can do it. Kidneys definitely play a role. I'm thinking fluid overload. If there's a lot of excess fluid in the body, it's going to make our arteries tighter, which is going to increase our pressure. Stress. Obesity. High cholesterol, because it's clogging our arteries. It gets a buildup of plaque, so the blood doesn't flow through as well. What is it in our diet that they tell us to watch? Salt, okay? So all of those are factors in raising the blood pressure or hypertension. So we want to tell people to diet, exercise, watch their fat intake. I do believe one of the test questions has something to do with hypertension education, okay? So those are the things. I know Mrs. Schmo talks about the salt substitutes, that you better watch out for those because they're really high in potassium. So if you're telling people to watch their salt and they're using a salt substitute and they're on a diuretic that doesn't get rid of potassium, that could be an issue. So you want to make sure you're educating your patients on that. Basically, if somebody comes in and they get their blood pressure taken, they've been driving to the doctor's office, they're hitting every traffic light, they're late, their kid threw up in the back seat of the car, they get to the doctor's office, they walk in, they sit down, the nurse takes their blood pressure. Anybody seeing any issues here? What is their blood pressure probably going to be like?
High.
Right. So do you know what they call that? When you
Stress-induced?
Yeah, white coat syndrome, kind of. Stress-induced white coat syndrome. You get to the doctor's office, you're nervous. So one of the things you can do if somebody doesn't have a history of high blood pressure is you'll want to take their blood pressure a second time near the end of the appointment, okay, to see if my daughter's is always high at the beginning of the appointment, okay? So if they don't have a history of high blood pressure, you're going to check it more than once. One of the best things I can teach you as a nurse, nursing instructor, if something isn't right on somebody's right side, then you better look at their left side. If you take their blood pressure on the right side and it's really high, you could take it again on the left side. But the thing you don't want to do is take it right away again on the right side, or it's going to be high, which I've had nurses and doctors' offices do to me. Okay, you should either check it again in the other arm or wait 15 minutes before you take it again, okay? If we are giving drugs to treat hypertension, what is the number one thing we are going to watch? Blood pressure, okay? So don't make it harder than that. It's the number one thing we're going to watch. We're going to watch it if it's high. We're going to watch it if it's low. As a nurse, it is your job to report a high or low blood pressure to the physician, whether you think that they're on meds or if the meds are going to take a little while to work or whatever. If it's high, they're at risk for what? They already have hypertension. Stroke or a heart attack, okay? So, and if it's low, what are they at risk? What do you think they're going to be like? Bleh. What's that? Yeah, they won't have a ton of energy. How about dizzy? Lightheaded? How about postural hypotension? Does that mean anything to anybody? What does that mean?
Like if you stand up too quick from a sitting position, your blood pressure will drop.
Yeah, you stand up too fast, your blood pressure drops, you get the almighty head rush. Okay? But that's a safety issue because people have passed out, fallen down. So if you're giving a blood pressure med and you're concerned that somebody's going to have, I mean, some of them are notorious for causing postural hypotension, but I would always keep it in my mind that you need to teach your client to rise slowly, wait a minute, and then start walking, okay? Because there's always that risk of them having low blood pressure. The number one line of defense for high blood pressure that the doctor's going to order first are diuretics, okay? And it's because of what Deb said up there. If they're having hypertension because of fluid overload, then we need to, what does a diuretic do?
Gets rid of the fluid.
Gets rid of the fluid. Okay, so it gets rid of the fluid, and what are you going to watch for? Intake and essentially output, okay? Some of them, like the loop diuretics, the Lasix, whether it's IV push or oral, they're going to start going to the bathroom a lot. So I don't know if you want to try to record on the board, but I'm actually going to make your first card for you, okay? So probably what I would do is I would look at my list, and we're talking about antihypertensive drugs, and we're talking about diuretics. And I see that there are 3 diuretics on the list, right? Okay? So I've asked you guys to use the generic names. So we're going to say furosemide and spirolactone. I think I spelled them right. Okay? Nope. That's wrong. Furosemide and, what's that? Okay. Okay. First I want to do hydrochlorothiazide, or HCTZ. Okay? So, you guys already showed me that you know what a diuretic is. They're all diuretics, or both of these are. And it helps to remove fluid from the body. Okay? So, we already said we're going to watch I and O, and mostly output, right? I said they're going to go to the bathroom a lot after you give this medication. So when should they take it?
Morning.
Because you don't want, especially an elderly person, getting up 5 times. That's a safety issue. So we can write to take it in the morning. Probably put it underneath. Okay? So we're giving it for blood pressure. What are we going to monitor?
Blood pressure.
Okay, so monitor blood pressure. And again, I would always watch for postural hypotension. Are these potassium sparing diuretics?
No.
No, what happens? You lose potassium, you lose electrolytes. So we are going to monitor what?
Potassium.
Okay. What is the normal potassium level?
3.5 to 5.
3.5 to 5. What I can tell you about potassium is it has huge cardiac effects, huge effects on the heart. So when it gets below 3.5 or above 5, dysrhythmias, arrhythmias, real severe cardiac problems, okay? What do they say? They say 8 is the gate. When that potassium gets to 8, see you later, okay? So severe problems, so we want to monitor our potassium level on that and make sure that it's staying within normal limits, okay? So we've got I and O, take in the morning, monitor their blood pressure, watch their potassium level, because these are diuretics, okay? On my same card, I'm going to write the other one I couldn't spell. Spironolactone. What's the difference with this one?
It's potassium sparing.
Okay. So we're gonna write potassium sparing. So that means somebody could actually get increased potassium. So what do I need to teach them?
About diet.
Diet. What about diet?
Don't eat things that are high in potassium.
Right, so do not eat things high in potassium. Because remember, low or high is bad. I wouldn't write anything up more than that on my card for those 3 drugs, all on one card. And what I'm trying to get you to see is if you can relate this to what you need to watch before and after. Okay, you're the nurse at the bed. What's their potassium like before I give it? What's their potassium like after I give it? Okay, what's their blood pressure like? These are the things you're going to teach the patient. These are the things you're going to watch for. Instead of putting all the different sections on your card, if you can just look at it and relate it to human speak instead of real technical, okay? Because I can get into with your ACE inhibitors and your prills, the renin-aldosterone, angiotensin system and all that stuff, but basically those drugs just help remove fluid and salt, okay? Which are the 2 things that increase blood pressure, the fluid overload and the sodium intake, okay, or high salt in the blood. What's your normal sodium level? Anybody know? 135 to 145 depending on your lab, okay? So remember, every hospital lab is different, but that's general. Okay, so these are your diuretics. We just covered all of those. So now we're going to talk about ACE inhibitors. Please make sure that you're looking at the suffix list. Your ACE inhibitors, your prills, your LOLs, your sartans, okay? So I just told you that even though I don't really have any highlighted on the test, I want to mention them because you're going to get them forevermore in other classes. Your ACE inhibitors basically work by, and your prills, your sartans and your prills, sorry, your ACE inhibitors and your sartans work by reducing the salt and the water in the body, okay? If you want to read through the RAAS system, you can, but that's basically how they work, and that's how it lowers the blood pressure. What is Kaolin, otherwise known as verapamil? Anybody know what that one is?
Calcium channel blocker.
Calcium channel blocker, antihypertensive. I'm giving somebody a pill for their blood pressure. What do I need to watch?
Blood pressure.
Their blood pressure, okay? So we need to be monitoring that. It can take a while to work. Anybody have any major side effects written down from those?
Cardiosuppression, peripheral edema, and constipation.
Yeah, I don't think there's a lot of side effects, but I would like you to look on the things that I uploaded to Moodle today and read about calcium. I might have shared with you guys that I take calcium sometimes at night to help me sleep, to relax me. So if you think about calcium working on the muscle, and the muscle is a heart, remember what we're trying to do is to take the workload off the heart, essentially, too, with some of these drugs, right? So if we can get the heart to relax a little bit, it's not working so hard.
So would you want to monitor their calcium too? On your-
You could. I didn't read that much about it being that huge of a deal, but you could. I haven't ever really given like calcium channel blockers. I will tell you, if somebody's calcium is high or low, then they are going to have muscle problems, and the heart's a muscle. So it's certainly not a bad idea.
So you could assess more for like, you know, payment or muscles or something.
Mhm.
You know, if something's going
You
on
could.
first.
Let's see. Hydralazine. What is hydralazine? Does anybody have notes on that?
Vasodilator.
It's a vasodilator. So what does that mean?
It relaxes the veins, not the arteries.
Yeah, so it's making them more relaxed so the blood can flow
So it's like-
easier.
So do we have to know that if an it makes the, I'm sorry, how can I word this? The preload is less. Are we gonna have to know? anything
Not for
about
this
that?
class,
Okay.
no. But I do want you to know that if I'm giving somebody a vasodilator and I'm taking their arteries and veins from this, okay, to this, and the blood is flowing through really good, probably this one is notorious for that postural hypotension. And again, if you're giving a blood pressure med, you've got to assess for low blood pressure as well as high blood pressure, okay?
Hold on here. Does it also relax the arterioles to
Not,
an extent, or not really?
yeah, I think so. I mean, when I think of vaso, I think of arteries, veins, everything the blood flows through. And then I have the allols. And I think on your list you have Inderal and low pressor. So what are we giving those for? Again, it's not a vasodilator, it's a beta blocker. I mean, potentially in the end it might come around to doing that because it's blocking the beta cells. But just, I want you to remember more that the LOLs are a beta blocker.
Sorry, it doesn't have anything really to do with it, but is low pressure the trade name or the generic name?
Metoprolol is the generic name and Lopressor is the trade name. Yep. So your allols are known as your beta blockers. Okay? So if you remember and you go back to when we were talking about sympathetic, parasympathetic, and we have beta in our lungs and beta in our heart and beta cells throughout our body, if we can block those, then it's going to relax. Okay? To decrease the workload on the heart, lower the blood pressure, but remember this one's notorious for something else.
Heart rate?
Heart rate. What kind of heart rate?
In
Low heart rate. Okay? So one of the side effects, or I won't call it an adverse effect, one of the effects of the medicine is that it will lower your pulse. Okay? Don't forget too that you could have somebody come into your office or be in the hospital and okay, you get a pulse of 40. You guys should be geared to look at their med list to see if they're on beta blockers, but who else would have a pulse of maybe 40?
Athletic people.
Yes, your
Right.
runners, your cardio, workout people.
My last resident or patient, she was really athletic. Her pulse was normally like 50-ish. So
Yeah.
she would always tell people when they did her vital signs
Not to panic. And then the other thing to remember too, if you're going in the morning at 7 a.m., the patient's been laying flat all night, okay? Their blood pressure and their pulse is probably going to be a little lower than once you get them up to go to the bathroom. So typically what we'll do when I'm working with students is if the people come through and they do rounds and they take their blood pressure and the person's laying down, when I go to give those 9 o'clock meds, we're going to take another set of vitals once they've been sitting up, eating, and use the bathroom, okay? The other thing that I want you to get used to doing, and when you're talking to your nurses in clinical, and you're kind of worried about giving a blood pressure med because their blood pressure seems kind of low, number one, the doctor's going to sometimes give parameters, but number two, what you're typically going to do is go back and look at the previous blood pressures before the other nurses gave the meds, before they called the doctor and held them, or before they gave the meds, okay? But you're always going to ask. Please do not go through a clinical day and not report to your nurse or your instructor a really high or a really low blood pressure, because you probably won't be finishing out the semester if you don't, okay? So make sure you're doing that. One of the things I forgot to mention on here, and I know Schmo's talked about it, and I'm sure Johanna has, the number one thing that you will get chewed out for by a doctor besides not knowing a patient's vital signs is not knowing their what? Weight. Why is that an issue? They're retaining water, their weight. So if a doctor orders a daily weight, they're very serious about a daily weight, especially if you're on a cardiac unit. There was a patient that had open heart surgery, went from ICU to the step-down unit, was there a few days recovering, got sent home, came back a couple days later. He had gained about 30 pounds from the time he was discharged from ICU and stayed in the step-down unit, but he still got sent home and came back with CHF. So it's unfortunate because I think his weight was recorded, but it just wasn't communicated, okay? And he could have potentially died, and I'm sure the hospital had to swallow the bill. So if somebody would have noticed that he gained that 30 pounds before they discharged him, he'd have been staying there and he would have been getting what types of medicine? Diuretics. And then depending on the type of diuretic, what else do you think he'd be getting? Potassium, okay? So that was a lesson learned. Anybody ever heard of clonidine, taken clonidine? Other name is Catapres. Some students have been given it for test anxiety, actually. And it has a potential for abuse
Doesn't it make you sleepy?
because it makes you sleepy. So people will use it as a sleep aid, okay? It also has anticholinergic effects. Do you know what that means? Anybody? I think this is one that'll give you, make you feel real dried up, okay? So if somebody's feeling dry, what can you have them do?
Some candy?
Dry mouth.
Some
Give,
candy?
yeah, if they're not a diabetic or sugar-free candy, suck on a candy. Drink more water. But don't go into fluid overload or we're going to have to put you on a diuretic. But clonidine is given for both anxiety and blood pressure, okay? Let's see, what's our next one?
Mini press?
Mini press.
So
What
for
is,
like all of these, the main thing that you're gonna monitor is blood pressure.
sure. If you're giving a blood pressure med, you better be watching the blood pressure. Prazosin, alpha antagonist blocker. So again, it's blocking something in order to get the results that we want, right, in the body. Anybody have anything written down about mini press? Because I need some help with this one.
That it reduces blood pressure for essential hypertension.
What is essential hypertension?
Unknown,
Unknown?
right?
It's just hypertension. It's, I don't know. I've read it in the book too, and I'm like, what's pre-hypertension? Anybody know?
Before hypertension.
What's that?
Systolic tachycardia.
Yeah, which do you think is more detrimental, your systolic or your diastolic being high?
Diastolic?
Your diastolic being high. And I have to tell you, my brother's on something, my best friend's on something. They both smoke, they don't exercise, they don't eat right. But I will tell you, if they quit smoking and exercise and ate right, they would not have to take their blood pressure med. So as a nurse, I feel like we should be advocating for that. And I will also warn you that doctors very freely give out the medicines of diuretics and antihypertensives. So I would think that you would need several documented high blood pressures in order to start somebody on medications, okay? But of course, in the meantime, if it's really high, you don't want to potentially send them in for a stroke, okay, or a heart attack. I have in my notes, again, monitor, it's a blood pressure med, so what do we need to be worried about? You know, not so much the diuretic things, but, you know, are they going to get dizzy when they stand up? Do you guys, I'm trying to think of the name. Oh, it's orthostatic blood pressures. Do you know what those are? What are those?
You take them when they're standing and then you take them
Lying,
after
sitting,
they
standing.
lay
Yep,
down.
lying, sitting, and standing to see the difference when they're getting up and down, okay? Which will basically be a good measurement for postural hypotension, okay? I have Lanoxin, digoxin from the digitalis plant. I think when meds come from plants, it's so cool. What is digoxin? What the heck does that do?
For your heart.
It's for your heart.
And don't give it if your heart rate is less than 60.
Okay, so Kirby says don't get if your heart rate is less than 60. So what is that telling us it must do to the heart rate? Lower it, okay? So that's typical, 60. Some hospitals are going to 55. So what I want you to think of with some of these drugs, if you've got a heart that's going lub-dub, 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 it's just beating away regular, it's not too large, everything's fine and dandy, it's working good, then you probably don't need anything. But if you've got a heart that's got a little arrhythmia, or it's enlarged and it has to work harder, these drugs will help slow it down and make it a stronger pump, okay? That's what digoxin does, all right? It's making it a stronger pump to get the blood out. It's taking the workload off the heart, okay?
So it's making it easier to work off.
Yeah. It's kind of giving it a break, giving it a breather, okay? Dopamine. Anybody know what that is? What does it say on our drug list about dopamine? Adrenergic agonist. Okay. Dopamine, dobutamine. Those are both used for treatment in heart failure, again, to take the workload off of the heart. I believe that dopamine helps with getting some fluid off, okay, to also take the workload off of the heart. So therefore, what am I going to monitor? Yeah, output. Are they losing fluid? Because if they are, if it's a good thing. If they're not, that's a problem. I believe when it's used in cardiac emergencies and you put that Foley catheter in with these, you'll see them really go to the bathroom, okay? You're pretty much diuresing the patient. How about amiodarone? Anybody heard of that one? I know you guys got cards sitting in front of me. Help me out.
It's an anti-dysrhythmic drug.
It's an antidysrhythmic, okay? So again, same thing. If the heart's going wickety-whack and not beating properly, it's not pumping the blood like a regular heart would. So if we can get it into a good rhythm, then it's going to be a much stronger, forceful pump, okay? I call this my Uncle Dave drug. This one was used a lot to treat shock, okay? Used in a cardiac emergency. But then they made it into a pill, and my Uncle Dave does take it because he's an AFibber. So his atrium don't beat normal. Some people have VFib, and that's when you would use it in a cardiac emergency, okay? Remember, when we're shocking a heart, we're stopping it. We're making the person not alive because we want the heart to use its memory and come back and take over beating normal, okay? Do you guys know what Starling's law is? No? Anybody open their book? I'm messing with you. I don't know. I don't know if it was in that good stuff reading. Starling's law talks about stretching of the heart. And if you take a rubber band and you keep stretching it and stretching it and stretching it and stretching it, what is it like?
Doesn't go back.
It doesn't bounce back. And that's what happens with the heart. When it beats funny or there's muscle damage, it doesn't bounce back to where it was, and that's why we have to give meds to help it work harder and stronger. Pulmonary toxicity. I would read about that.
That was the one we were just discussing.
Yep, and then I just said pulmonary toxicity as well. So what else am I gonna watch? Lungs, coughing, cold, pneumonias, okay? They're more susceptible. And if they already have a cardiac problem and then they get a lung problem on top of it, that's not a good thing, okay? And it seems like my Uncle Dave, because he is an AFibber, you know, he kind of gets short of breath and stuff easier because his heart isn't working as like mine or yours, okay? I just kind of watch him at family things, and he gets up for a little bit and then he's got to rest. We're going to jump from, these are all cardiac meds, okay? And this is still considered a cardiac med. My aunt had a heart attack and she's award winner of a stent now. But she got put on lovastatin or Mevacor. What is a statin?
Cholesterol med.
Cholesterol med. Well, why do we care about cholesterol?
It increases the chance of
Blockage.
cardiac injury
Cardiac injury increases the chance of cardiac injury from what?
from inflammation.
Blockage.
Vasoconstriction. The arteries actually get smaller in the veins from what's built up in there.
Plaque.
Fat, plaque, okay? So we give lovastatin to help with that. My aunt actually just asked to come off of it because she was having the typical side effects of lovastatin or statins. Anybody know what that is?
Is that RAH, not rhabdomyolysis, but something like that?
Muscle aches and pains, all her joints hurt.
Meiosis, is that what it is?
Rhabdomyolysis, yeah. Rhabdo is when all of a sudden it'll be so bad that your arm won't work anymore. I think I might have told, so it can result in severe rhabdo, okay? But in the meantime, you know, my aunt didn't get it that bad, but she said her joints and muscles hurt every day from being on it. I always talk about rhabdo. The patients that I've seen with rhabdo are the people, it just seems to me, that come into the ER because they got drunk and they passed out between the toilet and the bathtub in the cold bathroom floor. And they laid on their arm for about 15 or 20 or 40 hours, and now their arm won't work the rest of their lives because they cut the circulation off to it. Okay? So, yeah, I've seen that in a couple cases.
I was reading in the book, it says with this drug, the muscle pain, to check CK levels. What are CK levels?
Cardiac enzymes.
Cardiac.
Yeah,
Your muscles also make them.
yeah.
It's hard on the kidneys.
Well, it shows like muscle damage in the body.
Yeah, if people have high, or if they have dehydration, they monitor that too, because it'll tear up your kidneys.
Yeah, CKMB. So,
CK.
yeah,
They just said CK, they didn't say
Yeah.
put the MB part on there.
yeah. Some of them are CK, some are CKMB. But it shows muscle damage, okay? Questran. What do we give that for?
Cholesterol.
Cholesterol again, that nasty, nasty cholesterol. Does everybody have high cholesterol from eating fat? Why else would they have it?
They don't exercise.
Maybe don't exercise. Hereditary, okay? So I've seen little skinny tiny people that run 100 miles a week or whatever and eat right, and they pretty much just eat lettuce and seaweed, and they still have high cholesterol and have to be on cholesterol meds,
Like
okay?
the commercial where it shows the healthy coach just falls over dead.
Nice. There's been some pretty great new commercials I've been seeing for antidepressants. I mean, my husband and I'm like, I'll take the risk of being bipolar, okay? Because they're like, this drug can result in this, and even death, okay? You know what? I'll have my highs and lows, okay? I don't want all that other stuff. Okay. Yeah, so I don't know, it was just a very funny commercial. Questran is known as a bile acid sequestrant. When we talk about GI stuff, I kind of relate Questran to the same thing like Metamucil or something. Because when you take Questran, it just globs onto the fat and then you basically remove it from your body when you go to the bathroom. Not number one, but number two. Trying to be professional because you know it's going to be on YouTube. Okay? So it will reduce then, what are our cholesterol labs? What are you monitoring for cholesterol? Triglycerides? LDL? HDL?
Total cholesterol.
Okay. So which is our good cholesterol?
HDL.
H, so your heavenlies, okay? And then your LDL is the one you're going to want to go down, all right? Which they kind of, once you start getting to 200, it gets scary. I just found out too, like women at menopausal age maybe won't have high cholesterol their whole life, but then it'll start going up, so you have to watch it.
So this drug, a side effect is constipation. Is that because it has attached to that stuff? Is that why it's constipation, or is that anything?
Well, you drink it, and what do you think that you need to do a lot of then if it's going to work in your GI tract?
Fluids.
Drink a lot of fluid, a lot of water, or you'll get constipated. Okay? That's why it kind of reminds me of Metamucil. So you want to monitor your cholesterol labs, you want to drink fluids. I think the book also said it can give some GI upset or cramping, so you want to watch for that with your patients. Now we're going to talk about some anticoagulants, antiplatelets. And I might just group those all together on one card if you're feeling brave. You could. You could. Okay? So, don't forget my little hot tips on Moodle. Make sure if you're writing a card on heparin that you're seeing what it says on there. Okay? But what is heparin and why do we give it? Yes, ma'am. Yeah.
So you don't, like, it doesn't bind, so you don't bind, like, you don't get clots in places, like, they'll give them to, like, people who get, like, hip replacements.
Yeah.
Because you don't want people to have a clot here and then it goes straight to your brain and your heart.
So it makes your platelets slippery. And how I try to think of it is if you have a wound and then it gets swelling, and then what does the body try to do? Form a scab, right? Same thing happens in your body. You open the body up for whatever reason, your body's going to try to heal it there. So it's going to send platelets and it could form clots. So we need to keep everything slippery so it doesn't glob on somewhere and form a clot. Okay? Because what can clots do? Clog arteries and cause what?
PMI, stroke.
Pulmonary embolism, a heart attack, brain death, okay? So if those things bust off, that's could be a huge issue. So a lot of times post-surgery, post-replacement, post-heart valve, okay, post-stent, they may be hanging a bag of heparin for a little bit, okay, to keep everything flowing good and no clots. You can also give heparin sub-Q in the abdomen. Why would you do that?
Prophylactic food.
Prophylactic. Preventing deep vein thrombosis or blood clots, because are people in the hospital running around like I do at home, never sitting down? No. They're typically laying in bed, they're sick, they don't feel good. So the unit I was on, which was post-open heart, neurovascular, neurosurgery, everybody got either a heparin or a Lovenox sub-Q injection in their abdomen every day. Okay? So we don't have to worry so much about somebody bleeding out from that, But if they're on heparin IV, there is a huge potential for bleeding. I need you to know what happens to somebody that's bleeding out, okay? What
They
happens?
become very anemic, they'll go pale,
Pale,
they'll be cold and clammy.
cold,
Heart rate will increase
why?
because their blood is trying to pump more and more to get more oxygen to the tissues.
Yep, so the heart rate will go up,
Blood pressure will go down.
blood pressure will go down, bruising, ecchymosis, same word, hematoma, okay? Pardon?
Petechiae.
Yep, little red dots of petechiae, so you need to know those symptoms of bleeding, okay? As nurses, we have to be diligent at rescuing people when they're in an emergency situation, okay? When you get in higher level classes, you'll learn about heparin IV and how to monitor it. And, you know, at Borges, the nurses are kind of spoiled because the pharmacists do the dosing on the heparin, but other hospitals, the nurses do. And you'll learn that in Nursing 280. What is the lab that we're going to check for heparin?
PTT.
PTT, okay? So we're going to watch the PTT. I believe it needs to be 1 to 1.5 times the normal,
1.5 to 2
1.5 to 2. Thank you.
times their baseline.
Times their baseline to be effective and keep those platelets slippery. So they'll probably check somebody's before they put them on heparin, and those are the numbers the pharmacist uses to adjust their dose. I usually see on a pump numbers between 5 and 20. And that's it, mils per hour. When I start seeing over 20, I'm seeing a red flag. I don't even know if I've seen them as high as 20. So just, you know, just to be aware of your surroundings, if you walk in a room and heparin's flowing at 100 mils an hour, you better go get somebody. Somebody programmed the pump wrong. That's why they made smart pumps, so you could program in the drug.
Should be between 5 and 20.
You know, I'm just saying that I would never test you on that, but I'm just trying to show you that if you walk in a room and it's anything over 20, I'd be asking the nurse about it. Normal numbers are like 12 an hour, 15 an hour. Then the lab will come up, draw the PTT, the pharmacist at Borges will get the results. You'll get an order to turn it up to 18 for a few hours. They'll check it again, okay? Because it has such a high bleeding risk potential, they're constantly watching the labs and monitoring the rate, okay? People that get surgery for various reasons, then will go home on a drug called Coumadin or warfarin, okay? Coumadin and warfarin, you take it every day. Same kind of med, all right? Anticoagulant. If you have a knee replacement, hip replacement, especially if you have a heart valve replacement, you're going to be on Coumadin for a very long time, if not the rest of your life. With Coumadin, you monitor different labs.
INR.
Your PT and INR. Okay, so not PTT, but PT and INR. We look at the INR and we like it to be between what and what?
2 to 3.
2 to 3. And even though Mrs. Schmo will throw me under the table for saying this, but if you look at your numbers, 2 to 3, if you're under 2, your blood's a little thicker or less slippery. If you're over 3, it's a little thinner or more slippery. So somebody with a heart valve replacement, the doctor might be more comfortable with it being a little higher. So if you see a 3.5 INR, go back to the history and see why they're getting it, okay? But basically, typically what happens with a person on Coumadin is they go home on Coumadin weekly and then bi-weekly and then monthly. They'll go to a lab and get their blood drawn for the doctor to monitor. There's nurses that all they do all day is look at INRs and call patients and change their dose. So a typical dose of Coumadin might be 2.5 milligrams Monday, Wednesday, Friday, and 5 milligrams Tuesday, Thursday, Sunday. And then go back to the lab in a couple weeks. We're going to draw your INR. The doctor's going to adjust it. Okay? So they watch that because they're at risk for what?
Clats.
Or bleeding. Okay? So we've got those risk potentials there. Lovenox is called low molecular weight heparin. So the things that drug companies are making very quickly and putting out very quickly, and it makes me very nervous, are your anticoagulants and your antiplatelets. Okay? Lovenox has been around for a while. It's also a sub-Q abdomen injection to help prevent DVTs, right? You don't have to, the glory of it and sending people home on it is that they don't have to have those weekly labs drawn. They don't need a PT-INR. It's based on weight or however. So that's the glory of it, but it's more expensive and you have to make sure somebody knows how to give themselves an injection or the caregiver knows how to give an injection. It's got a pretty good low risk rate. Okay, I'd be okay going home on Lovenox. I'd be okay going home on Coumadin. But when they start sending me home on something like Xarelto, which is the next one on your list, there's no antidote. So these new ones that they're making have no antidotes. So if you're bleeding, and there's no labs to really check, you're just going to bleed. There's nothing to stop it. And we were giving drugs to patients on 8 when I was on clinical last that nurses on the unit hadn't even heard of yet. Okay, and there's no antidote to stop bleeding. So that would make, those are things I would start watching if I was an everyday nurse on the floor and thinking about for my own family. I'll take the once a week blood draw and the hassle of the nurse call instead of a brand new drug that has, you're going to see a lot of like lawsuit commercials on these. That's what I think. Let's see. Oh, and Lovenox does have an antidote. It's the same antidote that we give for heparin. Do you know what that is?
Protamine sulfate.
Protamine sulfate. So if someone's bleeding out on heparin, then you're going to give them protamine sulfate. That's the antidote to stop the bleeding. A lot of them you can't give to pregnant women. Okay, does that make sense? Because it'll cross the placenta. So you want to read which ones those are. What is good old aspirin?
Antiplatelet.
Antiplatelet. Okay, so don't underestimate the power of an aspirin.
I have a question.
Yeah?
Are we gonna have to know the milligram dosage for, just for the platelet function on that?
No, I want you to think more general. More general. Giving it to make the blood slippery so somebody doesn't get a clot is fine with me.
Okay.
Okay? And then watching for signs and symptoms of bleeding and what labs to monitor. Okay, I wouldn't go any deeper than that.
As far as the Lovenox, because, or not the Lovenox, the other one.
Xarelto,
Yeah,
Coumadin.
because there is no antidote, and there's no lab, so you would.
No, the Lovenox has an antidote of protamine sulfate, but the Xarelto does not that I know of.
Right, so you're still gonna monitor for signs of bleeding, so.
Yes, absolutely. Absolutely, and you're
What do
going
you
to
do in
teach.
that case? Just discontinue the drug?
Yeah, it's a waiting game like when I got the Michael Jackson drug. You just wait for it to wear off, I guess.
That's not.
Yeah, so that's why I'm saying I could see a lot of commercials in the future about some of these new blood thinners that I didn't just call blood thinners, okay? Aspirin, don't underestimate the power of an aspirin. When I talk about aspirin, I feel like I kind of have to give you a general overview of stroke because I'm a neuro nurse at heart, so I just have to. And earlier I called it a brain attack because I think people will pay more attention to like heart attack, brain attack than stroke, okay? So what is the number one thing that causes a stroke? What is it? Blood clots. So the majority of the strokes are ischemic strokes caused by a blood clot, meaning a blood clot blocks an artery in the brain doesn't get blood, the tissue dies, you have brain death, okay? That's what the majority of them are caused by. The other kinds of strokes are called what? Hemorrhagic. So embolism, I kind of think the same as a clot, but hemorrhagic is a bleed, okay? So you've got bleeding in the brain. The signs and symptoms look about the same, okay, on a patient when they present with a stroke. But the thing to know about aspirin is if somebody's having the signs and symptoms of a stroke, give them an aspirin. If they're having signs and symptoms of a heart attack, give them an aspirin. It'll help make the blood slippery and not clot, okay? If they have a hemorrhagic stroke, one aspirin's not going to make them bleed more, but it will help with the clotting, okay? So don't underestimate aspirin because it's a really good antiplatelet and it's used often post-surgery as well. People will go home on aspirin. Plavix, what is that?
It's the same antiplatelet.
It's an antiplatelet aggregation.
Yep, so antiplatelet, and the interesting thing about Plavix is once they put you on that, which is usually after an open heart or a stent placement, you're going to be on it for the rest of your life, okay? So protamine sulfate is to heparin as vitamin K is to Coumadin. So Coumadin's antidote is vitamin K. What kind of food do we find vitamin K in? Green leafy vegetables. Okay? So my mom was on Coumadin, so she was told to decrease her intake of green leafy vegetables because they didn't want her blood being more thick from the green vegetables when they were trying to keep it more slippery. Do you see what I'm saying? So you're going to be teaching diet to people that are on Coumadin. If you're restricting people from food, talk about the things they can have, not the things they can't have. Okay? My mom would go, I can't have salad. I'm like, you never ate salad. Okay? So that's just where people's mind goes. What is alteplase?
Thrombolytic.
Yep, it's a thrombolytic, meaning that it will bust. It is a clot buster. Okay? They use it in IV and PICC lines when they get clotted, but the main thing I want you to know about is they use it for strokes. And basically it has to be given when? Within 3 hours of the onset of symptoms. Otherwise, the reason it doesn't do any good after that is because brain death has already occurred. Okay? So again, huge risk of bleeding when this is given. Alteplase, Activase, TPA, those are all the names that are used for it. Okay? But if you can get somebody that's having symptoms of a stroke to the ER within 3 hours and they've determined it's an ischemic stroke caused by a clot, they can give this and the results are amazing. Okay? The problem is we all have denial. And so we will kind of talk ourselves out of the symptoms that we're having are probably not a stroke. And then it could be too late. So somebody has the symptoms of a stroke, which are what? Maybe drooping, or their words aren't coming out right, or one side doesn't work. If you can get them, if they're coherent enough to take an aspirin and call 911, that's what you need to do. And that's the end of my story. Kirby. Cut.